All right, welcome everyone to the University of New Mexico Law and Mental Health Didactic Series. This series is hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so glad to have you all here joining us today. My name is Julie Brovko. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. So don't forget that next week we have Dr. Maureen Reardon presenting assessment of mens rea and other partial mitigating defenses. Next for our talk today, please ask your questions in the Q&A anytime you feel comfortable. Just please know we're probably not going to get to them until the end. We do try to get to as many of your questions as possible, but please forgive me ahead of time if we can't get to yours. For those of you who want CEs but are on a tight schedule, you need to stay for the full hour, but you don't have to stay longer than that. So the talk is officially over at the hour, but we will likely be staying on longer to answer questions. For those of you who are here for CMEs, those are the medical CEs, you want to go to the sign-in sheet, which is posted in the chat now. For those of you who want the APA CEs, you're going to wait until the last 5 minutes of the talk today, and we're going to post a link to the survey. You'll fill out that survey. If for some reason it seems like it's not working, give it a few minutes or a couple of hours, come back to it, and then just make sure that you print your certificates or save a copy somehow, because we don't keep copies of those and we don't email them to you. As for the recording and the PowerPoint, we should be uploading those in about a week. You should see in our weekly reminder emails, we are now including that Google Drive link that includes all of the talks and the PowerPoints from previous weeks. So that's where you'll find this one, but again, give us about a week. I think those are all the announcements for today. So now I'd like to introduce to you our speaker for today, one of the University of New Mexico's very own postdoctoral fellows, Dr. Tatiana Matlasz. Dr. Matlasz completed her predoctoral internship with BOP in Butner, North Carolina, and she received her Ph.D. in clinical psychology from Louisiana State University, where she studied under Paul Frick. Dr. Matlasz has worked in a variety of clinical and forensic settings, such as inpatient hospitals, a county jail, a federal prison, substance use treatment facilities, private practice, and a court clinic. And she's published manuscripts related to violence risk assessment and competency assessment. Dr. Matlasz takes a lifespan developmental approach to understanding the most severe emotional and behavioral problems that put individuals at risk for involvement in the legal system. Therefore, a great deal of her work has focused on antisocial individuals with callous and unemotional and psychopathic personality traits, including ways to improve the assessment and treatment of this population. As such, she's particularly interested in the topic that she'll be presenting today. Dr. Matlasz, I'm so excited to have you here and to introduce you. I'm honored to welcome you, and I'm now going to turn it over to you.
All right, thank you, Julie. Thank you for having me here today. So a lot to talk about on this topic. So I'll be discussing, diagnosing antisocial personality disorder, the important but sometimes overlooked roles of persistence, pervasiveness, and psychopathy. So I'll just, Julie just went through this, so I'll breeze through that. She went through this as well, kind of your run-of-the-mill disclosures, as well as disclaimer. So hopping right in, like I said, a lot to talk about on this topic. And so, it's hard to narrow it down to even what we'll discuss today. So there's going to be a lot of paths that we're purposely not going to go down just for the sake of time and to try to stay within the scope of this presentation. But we'll have time for discussion at the end, like always. So, and I'll put my email in there too. So please feel free to email me and we can go down any and all of the rabbit holes that we don't go down today. So, all right, so just kind of an overview of today's talk. So antisocial personality disorder, or ASPD, it's a very real diagnosis and a real mental health problem with far-reaching impact that needs way more attention than it's currently getting, at least less stigmatized, less negative attention, and more funding, research, and treatment. But there also seems to be maybe a bit of a problem with overdiagnosis of ASPD as well. So we'll talk about why this is and why it might be, and how we might be able to correct this. And one of the things that might be contributing to the misdiagnosis and subsequent overdiagnosis of ASPD and it's just kind of an interesting discussion in itself, are limitations to the current diagnostic criteria for ASPD. Also want to acknowledge right up front that in general, there's a lot of debate in the field surrounding approaches to diagnosis and conceptualization of disorders. You know, some of it's a little more nuanced, some of it is more controversial. But, you know, there's not one right approach or way of thinking. So I just want to make that clear right up front going into this talk, and hope that this can be more of, you know, an intellectual exercise and, you know, just provide some food for thought rather than this be a lecture. So, but then also kind of on the other hand, while these can be really stimulating debates to have, you know, wherein there might be more than one right answer or approach, when we're talking about diagnosis and the diagnostic criteria that the majority of practitioners are using, it's probably better for things to be a little more black and white, and there'd be less room for interpretation there. And this is particularly problematic if having some sort of diagnostic gray area leads to misdiagnosis of a disorder that is so stigmatized and can have particularly negative outcomes for the individual receiving the diagnosis, as is the case with ASPD. So I'll talk about some of those implications associated with an ASPD diagnosis, as well as provide some recommendations for practitioners who might be considering this diagnosis. All right, so antisocial behavior is, you know, pretty diverse and heterogeneous. So this can be anything from lying or skipping school and work to using substances, purposely manipulating other people, getting in fights or seriously harming other people, just to kind of name a few. And so when this antisociality or violation of others' rights and criminality is pervasive and shown from childhood or adolescence and continues into adulthood, that's when we think of it as being antisocial personality disorder. And just kind of a quick note, ASPD is not psychopathy, even though there is this distinct subset of antisocial individuals who show psychopathic traits, but most do not. We'll talk about that more kind of throughout the presentation, but for those of you who might not be as familiar with this topic, just wanted to make that distinction right off the bat. All right. And then, you know, individuals with higher psychopathic traits have their own kind of distinct etiology, but since we're talking about ASPD more broadly, I'll just kind of briefly talk about where it comes from. So, you know, some level of antisocial behavior is, you know, somewhat normative, and then higher levels of antisocial behavior are even more normative at certain developmental stages. So, for example, toddlers can be pretty aggressive, but they tend to grow out of it. You know, we stop hitting each other to get what we want for the most part, hopefully. And then, you know, we see another uptick in adolescence. So this is what Terry Moffat kind of calls like the maturity gap, or what we think of, you know, when kids are figuring out who they are and, you know, this identity development phase. So what's considered normal antisocial behavior at that age kind of raises a little bit, but then there's some adolescents who engage in even higher levels of antisocial behavior than their peers. And so for some, we see this emerging right around puberty, where they are engaging in higher than normal levels of antisocial behavior. So they might get diagnosed with oppositional defiant disorder or conduct disorder. But this behavior is pretty transient and it seems to drop off after adolescence. So this is what Moffat calls these adolescent limited offenders. But then we see this group who don't fall off after adolescence. And, you know, we see that they're always a little bit higher than their peers and whose antisocial behavior tends to start a little bit earlier, some of them even as early as childhood. And for that group, we see differences in their biological and environmental makeups that seem to interact in the first 2 decades of life to gradually create this disordered personality that is really pervasive and permeates different domains of life. So that's kind of what we would consider those life course persistent offenders or people with antisocial personality disorder. Now there's a lot of different factors that contribute to someone developing antisocial traits and getting on this trajectory or that lead to ASPD. I won't go into too much depth, but you know, we see that it's fairly heritable. So we see these genetic contributions. There's also a lot of environmental factors that contribute to ASPD. And this isn't an exhaustive list by any means, But, we see there's different parental factors like poor parenting strategies, parent substance use, parents engaging in, some sort of domestic violence, and, untreated mental health problems of their own, abuse, neglect, kids getting exposed to violence in the neighborhood as well. So essentially we see, in this list, a lot of things that denote early life trauma of sorts. So, researchers have hypothesized that, it's possibly a combination of these factors that can lead these individuals to having both higher levels of emotions. So, having a harder time regulating their emotions, as well as also having kind of like too low of certain levels of emotion. So just not caring. And together this can lead them to have higher levels of impulsivity and aggression, and ultimately lead them to engaging in the antisocial behavior that we see. Now, ASPD, it's not too common in the general population. So the DSM kind of notes a 12-month prevalence rate of about 0.2 to 3.3%. And then the literature, pretty similar rates. But we see it's a little higher in men. And it might actually be even more inflated, but we'll talk about that more later, like I said, reasons why that might be. And then we see much, much higher rates of ASPD in populations of individuals who are coming from lower socioeconomic status. So because of that, we see ASPD as much more highly correlated with things like poverty, homelessness, substance abuse, unemployment, et cetera, et cetera. And then DSM also notes that we see higher rates of ASPD in samples affected by adverse sociocultural factors, which is also somewhat related to lower SES. And then we see that ASPD is diagnosed much more highly in correctional or offending populations. So it depends on the study, but generally we're seeing that about 50 to 80% of inmates are getting diagnosed with ASPD. And this isn't just in the US, it's, even in international studies. So in case you missed it, it's a really, really high stat. So 50 to 80% of inmates are getting diagnosed with ASPD or have a diagnosis of ASPD. And, I really want to highlight that because I think that's a really, really high percentage. And especially for a personality disorder, which is, something that we generally think to be fixed and resistant to change. So keep that number in mind as we move forward. All right, so question is it possible then that we are overdiagnosing ASPD? And of course, when we get into the limitations of the criteria, we'll talk a little bit more about reasons why this might be the case. All right, and you might know, especially if you've been following the series, that correctional facilities house more people with mental health problems than any other type of facility in the US. So maybe that stat I presented isn't too surprising. And also, then unsurprisingly, ASPD is comorbid with a lot of other disorders. So about 90% of people with an ASPD diagnosis have at least one other diagnosis. And again, not a comprehensive list, just a few that I wanted to highlight, but we see that they are diagnosed with a whole mix of other internalizing and externalizing disorders. So the population that we see the highest rate of ASPD in are individuals with substance use disorders. So it's about a 70 to 85% comorbidity there, which is, again, I think another really high stat. But not surprising given that people struggling with addiction often end up engaging in behaviors that maybe they wouldn't if they weren't high or trying to get high again. And unfortunately, that can lead them to coming into contact with our legal system. Then, about a third have a diagnosis of ASPD and ADHD, but, some of those criteria directly overlap, like impulsivity. So again, maybe not too surprising. Somebody with an ASPD diagnosis, 4 times more likely to have a diagnosis of mood disorder. About half have a lifetime anxiety disorder. We talked about a lot of trauma being kind of involved in their environmental factors that can lead to this diagnosis. So, unsurprisingly, individuals with trauma histories are 5 times more likely to have an ASPD diagnosis. And then we see about a quarter to a third have comorbid PTSD and ASPD. And then lastly, individuals with ASPD are 7 times more likely to have suicidal ideations and 9 times more likely to have made a suicide attempt. All right. So what I think the takeaway here is, or maybe kind of some food for thought, is ASPD then a behavioral manifestation of some other untreated needs. All right, and so before I get into the criteria for antisocial personality disorder specifically, what's a personality disorder more broadly? Well, the DSM states that it is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. The DSM also notes that it must be distinguished from simply being personality traits that don't reach the threshold for personality disorder, and that traits are only diagnosed as a PD when they are inflexible, maladaptive, and persisting, and cause significant functional impairment or subjective distress. All right, and then the APA similarly says that personality disorder is a way of thinking, feeling, and behaving that deviates from the expectations of the culture, causes distress or problems in functioning, and lasts over time. So we'll see I highlighted a bunch of words in red. So these are kind of our personality disorder buzzwords. And there's a lot of debate in the field about how to conceptualize personality disorders, but that could be a whole other talk in itself. So, but currently, according to the DSM-5, which is what we'll be talking about today, this is what constitutes a personality disorder. All right, and so before I talk about the DSM-5 criteria, just a quick note, it didn't change in the DSM-5 TR. So these will be the same. And also, I could have gone over these earlier, like right at the beginning, but I want to go over them now, right before discussing limitations so that they're fresh in everyone's mind. So essentially, the first one, criterion A, is a pervasive pattern of disregard for and violation of the rights of others occurring since age 15 is indicated by at least 3 of the following 7 things. So first, we have failure to conform to social norms with respect to lawful behaviors, so essentially repeated arrests. Second, we have deceitfulness or repeated lying, use of aliases or conning others. Third is impulsivity or failure to plan ahead. Fourth, we have irritability and aggressiveness, might be indicated by repeated physical fights or assaults. Fifth, we have reckless disregard for safety of self or others. Sixth, consistent irresponsibility is indicated by repeated failure to sustain consistent work behavior or honor financial obligations. And lastly, lack of remorse is indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. And then like all PDs, they have to be at least 18. And then criterion C indicates that they must have had some sort of evidence of conduct disorder with onset before age 15. So essentially kind of show that it's been persistent throughout the life. And then lastly, the antisocial behavior essentially can't occur exclusively when somebody's having, essentially a psychotic or manic episode. All right, so this brings me to the limitations to the DSM-5 criteria for ASPD. So I've hinted at some of these throughout, so some might not be too surprising. I do want to get in the weeds a little bit here, but hopefully not too much. But I think what you might find is that it's not so black and white. There's a lot of gray area and different ways to think about some of these things. And so I think this is why there are limitations maybe to the criteria and the DSM and not so much practitioners, because I think it's great that we all think so differently and have different approaches. But if it all comes down to us using one book or one manual to diagnose, it's probably best if it's a little more clear cut and there's less room for individual interpretation. So if you take a look at the literature, there's a few things that commonly pop up as criticisms of ASPD. So the biggies are that it's too heterogeneous, over-inclusive, and there's too much overlap with other disorders. So essentially saying that we're casting a wider net than makes sense. And then that last one, some of the literature talks about problems with criterion C, and not that it's a criteria itself, but how practitioners are using this. So we're being asked to diagnose this retrospectively, essentially. But some of the literature talks about clinicians maybe not having enough data or making assumptions that it existed. And so just assuming that they're meeting criterion C and maybe not having enough data to say for sure that they do. So this might be leading to inflated rates of ASPD diagnosis. That's kind of what the literature says. So here are some limitations that I want to kind of cover today. So the first one we have here is there's no specific criterion stating not better accounted for by, and, we see these in other DSM diagnoses, so you might be familiar with this one. And so I first want to note that this is a general criticism of all personality disorders, not just ASPD. So none of them have this as a criteria. And then I also want to note that there is this differential diagnosis section, like a little paragraph after the ASPD criteria, but it only really discusses substance use disorders and other personality disorders. It doesn't really get into other ones. But we know that there's this really high rate of other diagnoses and comorbidities with ASPD, including other disorders where the symptoms directly overlap with ASPD criteria. So what about those other factors or symptoms or disorders? And what happens if some of these other issues are addressed and all of a sudden the person looks quite different? Or what if we did a full assessment to really rule out these other disorders and make proper differential diagnoses? Or even just, in your assessment, ask the individual about the cognitions underlying their behavior rather than just looking at collateral records or making assumptions about the motivation for their antisocial behavior. All of these things could really help us suss out if what we're seeing is, truly stable traits that are resistant to change, or if some of these behavioral manifestations are simply due to something else that is amenable to change. And when it does change and remit, that antisociality kind of remits with it. And the DSM might be making some assumptions that users of the manual are using their training and judgment to do this already, but we also know that training varies. And we also know that that kind of not better accounted for criterion is listed for a lot of other DSM disorders, and it's not listed for PDs. And there is these high rates of comorbidity with ASPD and other disorders. And I'll also note that the DSM-5 TR did add an extra kind of comorbidity section that lists some of these things, but they're not included in the differential diagnostic discussion. And because this isn't listed as a criteria, I think it kind of muddies things up a bit and makes it a potential limitation to the criteria. All right. There's also no specific criterion for functional impairment. Again, this is kind of inherent in PDs. So this is something that the practitioner, of course, could use their good clinical judgment and would know to assess for. And then I also want to note that while this isn't a specific criterion for ASPD, it is reflected in some of the ASPD criteria itself. So things like not holding a job, getting in physical fights, getting arrested repeatedly. So things that could strain social relationships. But, depending on the 7 items and which 3 the person is meeting for or more, functional impairment might not be totally implicit. So it is up to the clinician to make some determinations about what constitutes functional impairment for the individual who's sitting in front of them. And so I think for this population in particular, this is an interesting question to consider. So what does constitute impairment? And when we're assessing impairment, what problems is a person having? And what's contributing to how we are determining if something is impairment. or not. And I ask this because, think about the population that this diagnosis is overrepresented in. A lot of the time, clinicians are saying that impairment is evident in the number of arrests or the fact that they're currently incarcerated. But do number of arrests or incarceration equate to impairment? Or for some, might it be a goal or culturally normative? For example, individuals who are homeless, the idea of, 2 hots in a cot or 3 hots in a cot is a phrase for a reason. So some people get incarcerated for a reason. Same thing, gang members. Gangs have a certain culture of their own. And so getting arrested and incarcerated might be a form of initiation. Some people might say, all right, well, if somebody desires to get incarcerated, that's still not a sign of positive adjustment. And that's still something that is indicative of, a potential disorder and something that requires treatment. But again, I think this is something where there isn't one right answer. And it isn't necessarily black and white. So I think kind of just, again, more food for thought, something that's interesting to think about. All right, so next one, no criterion to consider flexibility or adaptiveness of traits. Again, somewhat inherent in the definition of PDs because they're characterological, stable, and pervasive across contexts. But again, there's no specific criteria for this, which leaves room for interpretation. In the DSM, after the ASPD criteria, there's this specific culture-related diagnostic issue section, which touches on this. And the TR expanded on it a little bit, which is good. Still just a short paragraph though. And it essentially explains that ASPD is associated with low SES in urban settings, in which certain behavior might be part of a protective survival strategy. So we might see individuals engaging in certain behavior because it's adaptive or it's a reaction to their environment, and it's just contextual. It's because they're in that environment. And so even though it's seemingly antisocial behavior, and it would clearly meet for those different items in criterion A, if you take them out of that environment and they're no longer engaging in that same behavior, then it wouldn't be pervasive and it's not a personality disorder. So kind of related to that, the person engaging in those behaviors might not see their behavior as deviant or wrong or bad, which some might argue is true for all people with personality disorders. But I think that there's kind of a qualitative difference between, the environment of individuals with ASPD and other personality disorders, because, while the etiology is clear for all PDs, and we can say certain environments are likely to breed certain traits, usually we're not talking about a whole multi-level environment, potentially involving the individual's school and home and neighborhood and work, et cetera, all those different systems that they're interacting with on a daily basis. Usually when we talk about the environment that leads to certain traits or diagnoses, it's usually much more restricted than that, and not as pervasive as the environment that we refer to when we talk about ASPD, which I think makes it a little qualitatively different. And then also, since we know that individuals with ASPD are more likely to get arrested, and repeated arrests are actually a criteria for the disorder, the other environment that they are spending a lot of their time in and likely getting assessed for this disorder in are correctional facilities. And so essentially we're thinking about a group of individuals who, again, I'm generalizing a little bit, but for a vast majority of these individuals, they're coming from really crappy, high-risk traumatic environments and moving to correctional facilities, which, as we know, are other very crappy, kind of high-risk, trauma-filled environments. So they're just kind of going in between these two high-risk environments, which I think is relevant here when we're thinking about, those culturally relevant issues. And so a lot of food for thought here. And, I don't think there's any right answers, but kind of interesting to think about. So, it's really hard to assess for flexibility of these traits or behaviors, particularly if the individual is only going in between these environments that are very similar and high risk like I was saying. So I guess one of the questions I have is, what if they've never been given the opportunity to show whether or not these are traits or simply just a response to their environment? So how do we know if these traits really are rigid or if they are flexible? Then of course, the other side to the argument is, all right, well, low-income neighborhoods with high crimes don't necessarily view crime as adaptive or good, but they're stuck in those circumstances. They'd love to solve the gang problem and the violence problem and be able to raise their families safely. They just don't trust the police or the judicial system to do that for them. And so how do we know, everybody in that environment isn't necessarily engaging in antisocial behavior? And how do we know if the behaviors they're engaging in are protective or, more normal for that environment? We just, it's a hard thing to assess. And then also, just because a lot of people from the same area have the same disorder doesn't mean that it's not a disorder and something that needs to be treated. So kind of different ways of thinking about this and looking at it. And then regarding what is adaptive or maladaptive, again, some room for interpretation. Because, on one hand, one could argue that even if these behaviors are adaptive in the short term, they're likely maladaptive in the long run, which makes them overall maladaptive and potentially impairing. So for example, self-harm and avoidance are, short-term adaptive behaviors that people engage in, but they're ultimately maladaptive and things that need to be addressed. And also, regardless of their adaptiveness, they're still a symptom of a disorder. But then on the other hand, there's interpretations that may be more in line with the DSM cultural issues and certain behaviors being part of a protective survival strategy. But even this leaves room for interpretation. So, what does this look like in practice? So, I've taught anger management in lots of different settings, and how to, when you're presented with certain situations, how do you, when can you choose a more effective or adaptive way of responding? But if somebody, is being presented with a threat to their safety, I'm not going to tell them to use an "I feel" statement to get out of that. So that's unrealistic. But of course, it's a spectrum. So threat isn't always imminent. Thinking about prison, depending on the prison or jail, of course. If you're the new guy, it might be a good idea for you to pick some guy on your new unit and fight him, just to kind of establish yourself and show that you're somebody not to be messed with. Now that's purely proactive, instrumental aggression, but it fits with kind of the fundamental foremost value in prison, which is respect. And it could keep that new guy from being a victim, that day when he first gets there, and set him up for having a safer time while he's on that unit. So how do we figure out, is that adaptive or is that maladaptive? Because it's, it's kind of a hard question to answer. It's a lot to think about there. All right, and then just kind of quicker mention here, there's no guidance on reassessment. And the reason I think this is applicable for ASPD is because, you only need three of those 7 items to start. And if one of them is repeated criminal behavior and repeated arrests, but this is really common for people who are incarcerated, once somebody's incarcerated, there's a lower likelihood of them catching additional charges. So, but of course it's a personality disorder. So there's not going to be a specifier for in a controlled environment, because it should be pervasive across contexts. So how do we figure out when to reassess this or how to reassess this? So some further guidance on assessment and reassessment, especially with people who are incarcerated for maybe longer periods of time, could be helpful. All right. And then also specifically thinking about the ASPD criteria compared to other DSM-5 PDs, there are, like I've mentioned, kind of fewer criteria. So ASPD only requires 3. All other PDs require at least 4. And then all other cluster B PDs, which is where ASPD falls in that cluster, require at least 5. Now, one argument for this is that, well, they're a lot more serious than other criteria for other personality disorders. So 3 is more than enough. But we also know that having fewer criteria can lead to more heterogeneity in a disorder. And then it also lowers the threshold for diagnosis, making it easier for people to meet the diagnosis. And, you know, compared to other personality disorders, ASPD looks a little more behavioral. And then also just in comparison to past DSM criteria for ASPD, the DSM-5 is more behavioral. And this started with the DSM-3. So it started getting more behavioral at this point. And so it seems like there's not so much of a balance between affective, interpersonal, and behavioral criteria. Now, of course, behavioral manifestations could infer that there are affective and interpersonal difficulties as well, because, you know, these behaviors are often caused by underlying cognitive and affective factors. But if that was the case, we would expect that they would ding on other criteria. And they might if those other impairments exist. But if the criteria themselves don't even exist for somebody to ding on, and we're just making assumptions that somebody's behavior means that they have these other issues and that their whole personality is disordered, then that's the issue. That's the limitation. It's that ASPD is kind of lacking balanced behavioral, affective, and interpersonal criteria. And again, this is building on other limitations that we discussed, like the criteria not accounting for other reasons for somebody's behavior that, you know, might not be that it's antisocial, but, you know, manifestation of other issues. And so together, I think these are, you know, pretty big limitations to the ASPD criteria. So it's, you know, very behavioral, low threshold to meet criteria, and, you know, lots of room for interpretation. So with these limitations in mind, who are we trying to capture with this diagnosis? Because given the current criteria, we're not quite capturing psychopathy. So I won't go too much into depth about psychopathy, but it's essentially another kind of form of a personality disorder, but it's not a clinical diagnosis in itself. There is some overlap between, you know, the antisocial deviance and behavioral aspects of ASPD, but the core features of psychopathy are really those affective and interpersonal traits, like lack of empathy and callousness and shallow affect, kind of that superficial charm and being glib, and manipulating others, grandiosity, all of those kind of pieces. So the ASPD criteria really isn't capturing those parts, at least not fully, at least not in its entirety. So being so behavioral, it leans towards capturing, you know, criminal psychopathy, but again, not psychopathy fully, mostly just kind of that behavioral part. And so ASPD really isn't the full picture of psychopathy. And, you know, conduct disorder has a specifier to denote individuals who show all those behavioral problems, but then also have that affective piece. And it's called the with limited prosocial emotion specifier. We don't have anything like that for ASPD. And, you know, we're not quite capturing psychopathy, at least not anymore. So it seems like in the past, this diagnosis started out as a disorder to represent psychopathy. And over time, there was some divergence. So Hervey Cleckley was kind of one of the, you know, grandfathers of psychopathy. And so he wrote about being very pleased that it was in the diagnostic manual in the first one. And then he was even more excited with the second one. He said, here, the psychopath is officially designated as a personality disorder antisocial type, a recognizable entity and a fairly large group of different and distinct disorders. So he was jazzed that we had something in our manual to represent people high on psychopathy. But then once we got to the 3, it was more behavioral, and each new DSM became more behavioral. And we started kind of losing those pieces of psychopathy. And so again, even though they're confounded sometimes, like we've talked about, individuals high on psychopathic traits are just a small subgroup of antisocial individuals. Or perhaps if you think about antisocial behavior being on this spectrum, psychopathy would fall at that far end, representing the more severe and violent form of ASPD. But, you know, there's no diagnosis for psychopathy. However, there is one of those little paragraphs after the ASPD criteria called associated features. And this essentially lists off a whole bunch of different traits and behaviors that map more closely onto psychopathy and sound like psychopathy. The DSM tells practitioners to think about these things in your diagnosis of ASPD, but they're not listed as actual criteria. And they seem very different from what the criteria is. So it kind of, you know, muddies things up a little bit, and again, makes it very heterogeneous. And then kind of a last note here, not all individuals with psychopathic traits are getting arrested or referred for mental health services. Typically only the ones who are engaging in overt criminal behaviors. Because there are antisocial individuals out in the community who aren't ending up in jail or getting referred for evaluations. So we're not capturing them. So even if we were maybe trying to capture psychopathy with ASPD, it's still skewed towards criminal psychopathy because it's so behavioral. So again, who are we trying to identify with this disorder? Because, you know, it seems that given the limitations to the criteria, people are probably being diagnosed with ASPD maybe more often than they should be. And, you know, to me at least, it seems that there's kind of these three categories of ASPD folks. You know, we have the ones who truly do have ASPD. They have these rigid maladaptive traits, including maybe some psychopathic traits that started in childhood and have been persistent, caused impairment since then, and continue to do so no matter what environment they're in. So think about those PD buzzwords like persistent, pervasive, maladaptive, impairing, you know, true personality disorder. But then it also seems like maybe there are these people who are getting diagnosed with ASPD who come from a particular demographic and environment, who've been going from crappy environment to crappy environment and haven't been able to show otherwise, or haven't been assessed appropriately to really suss out if what behaviors they're showing are antisocial at their core. And then also there might be this group of people whose behavior is better accounted for by other untreated needs. Now, kind of hypothesize that might be what's going on from, you know, what the literature says and my own observations. So there's no hard data to back that up. But regardless, it does seem overdiagnosed and is overrepresented in a certain population. Which brings me to, why do we diagnose? You know, so just kind of going back to basics. We diagnose because it can put a name to an experience for the individual, and that can be therapeutic for them in itself, kind of help them through certain processes. It gives us a name or a shorthand to describe a collection of traits or symptoms or characteristics. Then we can use that name to communicate with each other in the field and communicate with other people outside of the field. And then we also, by being able to label these traits or cluster of symptoms, we can do research and figure out what, you know, treatments work best for them. And then practitioners can apply those treatments, and we can, you know, do research and apply research. So essentially we diagnose to help in some manner. So, you know, if you give me any common disorder and kind of run down this list and see how it lines up. But with ASPD, it doesn't seem to line up with the reasons why we diagnose quite so well. And again, this is probably true for other diagnoses, including other PDs as well. But, you know, we know now that there are reasons that we might be over-diagnosing it, which is problematic in and of itself. But it's particularly problematic because compared to a lot of other disorders, there's a lot of really serious implications and consequences that are associated with an ASPD diagnosis. So, you know, these individuals often are not self-referring for an evaluation or therapy. So they're most often being referred by the courts or, you know, in some criminal context. Now, much smaller portion are being referred for other reasons, but the vast majority, it's in a criminal context. So they're not asking for this evaluation or diagnosis. So already we're giving them something that they didn't ask for and likely don't want. And this is an implication all on its own and something to be mindful of. But there are multiple added levels that make this a particularly difficult or potentially unfortunate diagnosis for somebody to receive when they didn't ask for it. And most of that, comes back to ASPD being a very stigmatized disorder. And so I'll talk about ASPD, but externalizing disorders in general are very stigmatized. So I'll kind of talk about that as well. And this is both within and outside of the mental health field. So, inherently internalizing disorders and externalizing disorders are distinguishing from each other in that externalizing disorders like oppositional defiant disorder or ASPD are defined by engaging in behaviors that cause explicit harm to others, which have negative moral consequences. Whereas internalizing disorders like anxiety or depression are characterized by suffering by oneself, which is thought of as being morally neutral. And so a lot of people think about ASPD or externalizing disorders as being this volitional bad behavior rather than a real mental health problem. And all this might be particularly influential in creating bias in the way that ASPD and externalizing disorders are perceived by the general public. And the general public includes, practitioners themselves, members of jury pools, people who are reviewing academic publications or grants, as well as government officials and policymakers. And so, with certain behaviors that violate other people's rights, this leads to anger and inferences of intentionality and being blameworthy, and the desire to hold the violator responsible, which is not compatible with wanting to improve the welfare of the violator or the person engaging in those behaviors. But a lot of this comes back to that volitional piece, and externalizing disorders being somebody's choice rather than a mental health problem. And so that volitional piece is tied to personality disorders in general, but it's also tied to externalizing disorders by many. But I want to make the argument here that there is some volitionality in a lot of disorders, at least in comparison to others like psychotic spectrum disorders, which are not volitional. For example, somebody with anxiety, an internalizing disorder, just like they, might be presented with an anxiety-provoking stimuli and choose to avoid that. Somebody with ASPD might be presented with a certain stimulus that they choose to use aggression or engage in aggression. So, there's volitionality in a lot of disorders. But with externalizing disorders, because there's often a victim or, people are engaging in behaviors against others, it's more stigmatizing. And so the stigmatization and perception of it being immoral and a choice rather than a typical behavior has important implications. And so in clinical settings, first off, the research shows that individuals with ASPD are at risk for a whole bunch of different negative outcomes, personally for themselves, but then also because it's externalizing, their behavior also has these negative outcomes on potential victims and on society as a whole. And so their behavior and this disorder going untreated costs a lot to society, both financially and emotionally. So it's very far reaching, the impact of this disorder, and arguably more so than internalizing disorders for those reasons. But there's this general perception that treatment is less effective for externalizing disorders, which might be true, but we also know that there's a lot less treatment available for these disorders. So there are countless types of treatments that can be used for different internalizing disorders, but there's not much out there for externalizing disorders and very, very little for, PDs in general, but also for ASPD. And part of this seems to be because of the stigmatization against externalizing disorders like ASPD. And, research has actually found that externalizing disorders are the subject of less research. They get fewer grants and fewer clinical trials. And that doesn't reflect the prevalence of externalizing disorders in the general population or the amount of impairment or long-term consequences that they cause. And it also doesn't reflect how much empirical evidence there is showing that they have just as strong etiologies and genetic factors and neurological dysfunction as internalizing disorders. And so, research also indicates that, because people tend to view these disorders as more controllable and blameworthy, and in turn less reflective of mental illness and deserving of treatment, and more deserving of punishment, that's an obvious issue for clinical reasons, but because individuals exhibiting this behavior are often not engaging with mental health practitioners until they become involved with the legal system, this diagnosis has really serious implications for in the forensic context as well. So, like I said, they're usually not asking for an evaluation. A lot of the time they're getting this diagnosis without asking for it. They're being court ordered or their attorney is sending them for an evaluation. And this diagnosis might be shared with legal audiences and influence outcomes related to their legal situation, which can have really real impact on their life. And the research shows that an ASPD diagnosis can be very prejudicial in legal settings. So generally, a PD diagnosis infers rigid, unchangeable traits. But research shows that this diagnosis in particular can influence perceptions of guilt, decisions related to sentencing, conditional release or commitment determinations, et cetera. And, maybe perhaps because ASPD and psychopathy are sometimes confounded, sometimes the association of violence and ASPD is overestimated. But the research shows that when we're thinking about ASPD without that psychopathy piece, really, there's not a really strong connection between ASPD and violence, future violence. However, kind of supporting this idea that it can be prejudicial, we see from the literature that an ASPD diagnosis in legal settings is much more often used by the prosecution than the defense for things such as arguments that they may be dangerous or violent in the future. So it can be very prejudicial. And so few recommendations based off of everything that we've discussed. All right, so, we talk a lot about evidence-based treatment, but we can't forget about evidence-based assessment too. And that actually needs to come first before we can even do evidence-based treatment. So this involves, taking in as much information as possible, collecting all the data that you can. And, that means collecting any data you need to fill in any blanks, and understanding the context of behaviors in a variety of different settings, and then the nuances of the environment and how that impacts behavior. And then part of evidence-based assessment also includes reassessing. So of course, this isn't possible in all settings, but we need to reassess when we can. And so also part of this evidence-based assessment, making proper differential diagnoses. And, don't be scared to discuss this in a report, again, depending on the context. You might be able to explain what you're seeing and maybe that you're considering various diagnoses, and that if, certain recommended treatment is successful in managing, X, Y, and Z symptoms, then an ASPD diagnosis might not be warranted. But if after treating certain symptoms, you see that the ASPD or antisocial behaviors persist, then that ASPD diagnosis should be considered. You might be able to talk about that in reports depending on the setting. Based on our discussion of the various limitations, consider the individual's culture and be inclusive here. Consider the adaptiveness of their behaviors. And then think about those PD buzzwords. So is it pervasive? Is it persistent? And is it impairing? And what constitutes impairment? And then also part of collecting enough data and doing an evidence-based assessment, making sure that you have enough data or have the proper information to properly retrospectively diagnose conduct disorder before age 15. And then train other people to do evidence-based assessment too. So this could be your peers or supervisees. And so, yeah. Consider also why you're evaluating and diagnosing the individual. So going back to basics, again, why do we diagnose? And think about what the intended utility of giving that diagnosis is and who the intended audience of the information is going to be. And then in forensic contexts, as always, consider what's the referral question you've been asked to answer and what information is necessary to answer that question. Do you have enough info to give an ASPD diagnosis? And is that diagnosis relevant or necessary to answer the referral question? Or could it be prejudicial? And so, kind of taken together, I'm not saying don't give this diagnosis, because it is a real diagnosis, and there are people who have this. But because it's so stigmatized and because of the implications we discussed, I just want to emphasize only giving it when it's clinically warranted and evidence-based. All right, so just kind of my closing thoughts. Like I said, ASPD is a legitimate mental health problem, and it, with far-reaching impact. But current limitations to our criteria seems to have kind of muddied up the conceptualization and led to potential overdiagnosis. And so with that being said, what would we want to see in the DSM-6? I think I have just more an umbrella thought, who are we trying to capture with an ASPD diagnosis? And so what kind of criteria would we want to do that? And then lastly, I said a lot more blank is needed in the area of ASPD and externalizing disorders more generally, because I think you could throw a whole bunch of things into that blank. So we need more treatment, we need more funding, we need more research, we need a lot more of lots of things. So just kind of my final thoughts to leave you with. Thank you all for listening.
Thank you so much, Tatiana. We have tons of questions, which means that people are extremely engaged. I want to be the first person to say this was a fabulous talk. You did an amazing job. So first question, the very beginning of your presentation, you talked about resistance to change when you were referring to personality disorders. Can you just clarify what you meant by that term?
Yeah, so like I said, there's a lot of different ways to conceptualize personality disorders. But with the way that the DSM is kind of currently talking about them and conceptualizing them, we think about personality disorders as being kind of sticky, and there being these traits that are pervasive in a lot of different domains of life, like people's relationships and their work and in all sorts of contexts and environments. And so when we think about these being kind of traits, we think of them as being like core to somebody's personality, at least for the DSM currently. And so they seem to be resistant to change. So personality disorders seem to be harder to treat. And that doesn't necessarily mean that they're untreatable. Like I said, we kind of are lacking treatments in this area, but so that's the part that I was referring to with resistant to change, is that that's kind of the conceptualization that the DSM seems to be working off of currently.
Next question. This individual understands that per diagnostic criteria, an individual needs a history of ODD or CD prior to an ASPD diagnosis, but they're wondering if there's any data to show a diagnosis of ASPD without a history of ODD or CD.
So I think, with all personality disorders, there's that persistent piece. So needing to show that certain behaviors or traits began sometime in childhood or adolescence. And so no personality disorder can be diagnosed before age 18, but usually practitioners are looking for evidence of it before that point. And with the current criteria, we need to have some sort of evidence of that, like the conduct disorder diagnosis for ASPD earlier. Yeah, but it's hard to do that retrospective diagnosis unless the person gives you a lot of good data, or you can get collateral information to answer that. Yeah.
This next individual would like to know if there's a reason that impairment necessarily has to encompass cognitive, behavioral, or social limitations. And they're curious if impairment could constitute only negative effects on others.
I think that is an interesting question. I think that that's part of like it being a limitation, because there's, usually when we think about impairment in the DSM, it usually does specify like impairment in social, occupational, or vocational functioning. So kind of those main kind of pieces that this person first listed. So usually that's what's specified as functional impairment. But for personality disorders, it's not specified at all. So again, there's a lot of room for interpretation. So I think it could be what you want to interpret it as. And it's not really clear, but I think, yeah, it could depend on the person that you're evaluating and what seems to be impairing for them. Yeah, I think it's an interesting question though. Yeah, highlights that limitation.
So it is right at the hour. For those of you that need to jump off, now is the time. The link for the APACEs is in the chat. Anthony also put the link for our Google Drive in the chat. You should be getting those in weekly emails as well, but that Google Drive link is going to include the recording for this presentation in about a week, but it also includes all of our most of our previous presentations and the PowerPoints for those. So make sure you jump on and grab those. And also please make sure you save a copy of the CE certificate, because we don't send those out. Okay, so the next question is, do you think the current ASPD criteria are under-inclusive of females? And should we be looking more to the alternative model to better discern females who meet criteria for personality disorders?
Yeah, so that's another, maybe not a debate, but another topic of discussion in the field, is that since we do see this being much more diagnosed in males, like what is ASPD in females, and is our criteria just, more aimed at males, and are we kind of missing what ASPD looks like in females? I think in general, the alternative criteria does seem to give a little more specific guidance on what ASPD might look like. And it does talk a little bit more about the like self and interpersonal impairment. And a lot of the time, with personality disorders, maybe ones that are more common in females, like borderline, some of the criteria focuses more on that interpersonal stuff. And so I think maybe the alternative criteria might be more inclusive for males and females. Yeah.
So there's less information out there about people that meet criteria for both developmental disability and ASPD. And in this person's experience, there's an assumption in the community of mutual exclusivity, which doesn't seem to be the case clinically. For example, their ASPD traits can sometimes get in the way of testing. So if the person does have some kind of intellectual disability or cognitive deficits, those things might actually be underdiagnosed, and the person can miss out on essential services. And this individual wants to know if you have any suggestions about, kind of how to address this or what to do with this particular population.
Yeah, I think that's a great question. And I think there's certain, comorbidities where somebody might have a certain disorder and also have ASPD. But I think that's a tough one because, individuals with developmental disabilities, kind of comes back to that other limitation of, is it some other, is it something else that might better account for the antisocial behavior? So is it like, what are the cognitions that are underlying that? Like, so is somebody with a developmental disability, are they engaging in antisocial behavior because, they have antisocial cognitions and, that affective component that's motivating antisocial behavior? Or is it a behavioral component of the developmental disability? So I think that's, an interesting topic. in terms of recommendations for how to proceed, kind of in that same line of thought, if there's some way to treat or manage the antisocial behavior, if they are exclusive and somebody would meet for both of them, and you can, maybe work on treating the antisocial behavior better, and managing some of those symptoms, and to kind of clear the way to be able to do the ID testing and get them services, that would be helpful. But yeah, it's kind of tricky. I think a lot of it too depends on the individual that you're working with. So I wouldn't want to make any like broad statements about what to do.
I feel like that's a talk in and of itself, quite frankly.
Yes. I feel like there's a lot of talks within this talk.
Yeah. I know you touched on this a little bit, but there are clinicians who approach ASPD as tantamount to psychopathy, but then there's some texts that mention ASPD but don't talk about psychopathy at all. Do you have more comments on this or thoughts on this?
Yeah, so this is another thing that could be its own talk. So it's something that I kind of purposely didn't get too much into because there is so much to talk about there. Yeah, so there's differing schools of thought on this. So there are some researchers who think that ASPD and psychopathy are pretty distinct and should be very distinct constructs. And some people who argue that psychopathy is psychopathy all on its own, and that we don't even need the antisocial stuff, and that shouldn't even be included in our conceptualization of psychopathy, because the core pieces really are the affective and like interpersonal components. But then there's some people who do think of it as, the antisociality is the big part and psychopathy is just the more severe form of that. And so I think there's kind of conflicting thoughts in this realm. I don't know if that answers the question.
Okay, next question. Since we can't diagnose a personality disorder prior to 18, and most people follow this in regard to diagnosing or labeling psychopathy as well, what, if any, prodromal indicators of psychopathy have been identified in the research prior to age 18?
So that would be the research on callous and emotional traits. And so we actually have with conduct disorder in the DSM. And then if you use the ICD, I believe ODD, oppositional defiant disorder, and conduct disorder, you can add this specifier, the with limited prosocial emotion specifier. And that is for you're essentially identifying callous and emotional traits, which are what we think of as essentially the kind of the affective component of psychopathy in children and adolescents. And so because that affective component of psychopathy, compared to any of the other ones, the behavioral or lifestyle, any of those other parts that make up psychopathy, that affective component seems to be most predictive of adult psychopathy. And so we look at those affective traits, those callous and emotional traits in children and adolescents as, kind of an indicator of potential psychopathy. And you can add that to the diagnosis of conduct disorder for adolescents.
Do you know if there are any cultural implications that were added to the DSM-5 TR related to ASPD and the potential overdiagnosis of it in certain cultural settings like low SES, race, and so on?
So the cultural related diagnostic issues section was about this big in the DSM-5, and it's now about this big in the DSM-5 TR. It didn't change, it just kind of expanded on that point. And it basically, like I discussed in the one point, it essentially just says that ASPD is much higher in lower SES populations. And it indicates that, it might be like things that look to be antisocial behavior on the surface might actually be part of this protective survival strategy. And so just kind of beware that it could be, specific to that context and not pervasive and not actually antisocial behavior and not part of a personality disorder, but because somebody is in a low SES environment. But it doesn't get too in depth, but that's essentially what it says there.
So you touched a little bit earlier on the environmental factors that might lead to a misdiagnosis of ASPD. For example, like response to environmental factors like trauma. You also mentioned that there is a genetic association with ASPD. Could the fact that family members often have similar environments lead to one assuming a genetic component instead of an environmental response to similar stimuli?
Yeah, of course, but just like most research on like etiological factors, there are, twin studies and other studies that look at genetic components and even like brain abnormalities, all that kind of biological stuff, and compare people with different environments. To kind of parse apart what is purely genetic and biological versus environment. So, and that research shows and tells us that we can say there is this purely genetic component, in addition to there also being environmental. But of course, as we know, it's always nature and nurture. So it's kind of a combination of the two that puts people at the greatest risk.
So you made a really important point regarding the prosecution raising the issue of ASPD, but do you have any thoughts about how the defense could counter that? So for example, Adrian Rain has argued that ASPD should be conceptualized as a neurodevelopmental disorder. Thoughts on this?
Yeah, so I think the defense could probably get really crafty in lots of ways that they discuss this, especially if their client comes from certain backgrounds or has other diagnoses that are comorbid with ASPD. I think that there's different arguments that could be made. I think, of course, it depends on the individual. So I don't want to generalize too much, but I think, there's different ways that the defense could counter this. What was the other point I was going to say on that? I can't recall. I lost my thought. Yeah.
All right. We are 12 minutes after. So I think this is a good place to end. But again, really nice job. This was a fantastic talk, super useful. Really, really appreciate your time and all the hard work that you put into this. I'm so proud of you. Thank you everyone for being here. Please make sure you grab the link in the chat for your CEs. Make sure you save a copy. We will try to get this talk and the PowerPoint slides up in about a week. And we will be seeing you all next week. Thank you so much.
Thanks, guys.